because of the fact that the AUA guidelines for vesico-ureteral reflux were first published in 2010, and there's an update of those AUA guidelines coming up that is not yet published. What I decided to do is just talk a little bit about the evidence and really look at the evidence-based approach in children with vesico-ureteral reflux. In 1983, John Woodard, who was a urologist, said as one looks over the last 30 years of reflux history, it is ironic that urologists have become so expert at surgical correction before understanding so much of its natural history and to clinical significance. So when I was a fellow in Toronto, in 2 years we did around 300 implants. Today I hardly do 20. And I think what has happened over the years is that we've become very successful. Treating reflux is not a big deal. And operating for reflux is the open operations are highly successful. But I think what we need to do is you need to risk stratify patients and only treat reflux that is clinically significant. And that's our job to determine which kids are clinically significant, which are not, and that's what I'd like to present today. So reflux, the journey has been significant, and they started off with children where initially they thought it was a bladder neck dysfunction and did plasties of the bladder neck because they thought the bladder neck obstruction was a cause for reflux. Then Politano and Ledbetter came in with a reimplantation without bladder neck plasty and showed that there was significant improvement. Then there were studies in England by Dr. Smelly that showed that there's a very high spontaneous resolution rate and you don't really need to operate on every child with reflux, and that low-dose antibiotics reduce the risk of scarring. That we knew that episodic treatment of urinary tract infections with antibiotic prophylaxis had a higher rate of scarring compared to continuous prophylaxis. And surgery only if reflux did not resolve. But what has happened, this is up to 20 years ago, but what has happened over the last 20 years? Things have changed. There are several studies that have actually shown that maybe long-term prophylaxis may not be as beneficial as we thought they were, and that vesico-ureteral reflux in itself is not a disease, and it may be an independent variable that does not represent the risk of renal scarring. Maybe it's something else. It's not the reflux itself that is a risk for scarring, but something else like febrile urinary tract infection. And that we know that all the randomized trials that were published were flawed in their patient selection. There was selection bias in a lot of these studies. We know that acquired renal scarring occurs in around 15% of kids with reflux after a febrile urinary tract infections. The risk of hypertension and chronic kidney disease is around 20%, 10%. And interestingly enough, it hasn't changed very much over the years. And the reason, and what has actually changed and reduced the risk of hypertension and chronic kidney disease is that we treat pyelonephritis better than what we used to do. So pyelonephritis is probably treatment of pyelonephritis and treatment of febrile urinary tract infection, probably the most significant factor that has reduced the morbidity associated with reflux, not the treatment of reflux itself. And there's really there was no consensus as what is the best management of kids, and there's quite a bit of variation in practice. So what are the needs for kids with vesico-ureteral reflux? I think the age at the time that the kid presents is important. The character of the infection, what kind of infection is it? Is it a common E. coli infection or is it a Pseudomonas infection? How was the diagnosis made? Was the diagnosis made after a urinary tract infection, or is this an antenatal diagnosed reflux? What about the parenchymal status? Is there scarring or dysplasia in the kidney? Is it the single or duplicated system? Does that kid have bladder and bowel dysfunction? Does the kid have voiding dysfunction, the grade of reflux? And then also important is family reliability. Is the family reliable and compliant? Would they be compliant in taking antibiotic prophylaxis? And the primary aim of managing kids with vesico-ureteral reflux is to reduce the morbidity associated with febrile urinary tract infections and to prevent scarring. So what about evaluation? Those are 3 guidelines and imaging recommendations for febrile urinary tract infections. I'll go over the AAP guidelines or guidelines that came up the AAP guidelines are between 2 and 24 months of age. The NICE guidelines are the UK guidelines that are for all kids under the age of 16. And the AUA has, the guidelines are for children. I think both the AAP and the AUA guidelines recommend an ultrasound after febrile urinary tract infection in all kids. The NICE guidelines would recommend an ultrasound only for atypical urinary tract infections and for those with recurring UTIs. There are a lot of people who are against this guideline, and even in the UK, where they're seeing kids that have normal E. coli urinary tract infections have ultrasound abnormalities, and so there's a question about this recommendation by the NICE guidelines. The MSA scans, the AUAP does not recommend any. The AUA recommends as an option for high-grade reflux, and if the ultrasound is abnormal, the kid has recurrent febrile urinary tract infection. As far as VCUGs are concerned, the AP guidelines, and you know those, suggest getting a VCUG after a second febrile urinary tract infection, not after the first, or after the first febrile urinary tract infection if there is an abnormality in the ultrasound. So if the ultrasound, for example, shows hydronecrosis or scarring after the first urinary tract infection, then I would recommend a VCUG. Otherwise, waiting for a second VCUG for febrile urinary tract if the ultrasound is normal. There's been a lot of scrutiny of this recommendation, especially by pediatric urologists in the States, where the feeling is that a lot of times you may miss reflux even after a first febrile urinary tract infection. But again, I think this guideline is evidence-based, and doing it after a second urinary tract infection does not increase the risk. The AAP guidelines, the AUA guidelines 2010 don't mention that, but again, they would assume that they would go after the first urinary tract infection. There's been 2 different approaches of evaluating kids with reflux, either for reflux, either a top-down approach or a bottom-up approach. The top-down approach basically states that if you have an abnormality on the MSA scan at the time of the febrile urinary tract infection, your risk of detecting vesico-ureteral reflux is much higher. So really the top-down approach says get a DMSA scan first. If the DMSA scan is positive, then get a VCUG. If the DMSA scan is negative, you don't need to get a VCUG because your yield is small. And so that's a con. That in that fact, you can reduce the number of VCUGs that are done by 60 to 80%. But the problem with the MSA is the radiation dose. And so there's radiation involved with that. So is the VCUG. So there's debate going on between the top-down and bottom-up approach. The bottom-up approach basically get a VCUG first, and the DMSA scan only if there are abnormalities in the ultrasound or if it's a high-grade reflux. What about prophylaxis, UTIs, and scarring? So we talked about the fact that it's not reflux that causes scarring. Reflux, a lot of kids that are diagnosed antenally, that have renal abnormalities, have renal dysplasia. That's not scarring. Those are kids that are born with decreased function, but new scars in the kidney are only related with febrile urinary tract infection. So it's urinary tract infection, but that's causing new scars in the kidneys. And so your goal is to prevent kids from having febrile urinary tract infection. By doing so, you reduce the risk of scarring. It's also very unclear if new scars are preventable. So the RIVER study, I'm not sure if you knew, but this is probably one of the best designed prospective randomized studies that have ever been done in reflux. What they did is took kids and randomized them into prophylaxis and no prophylaxis. The indications for, or the definitions of febrile urinary tract infection were well defined. How would you diagnose a child with UTI? And so they looked at the incidence of reflux. The Swedish reflux trial also looked at kids under the age of 2 that had grade 3 to 5 reflux. Again, the definition of upper body urinary tract infection is questionable in this study. And the international reflux study was basically a reflux study. It was performed much earlier. It would have 2 arms, a European arm and a North American arm. It's really unclear if the downstream effect of reflux are modifiable. But what I mean by that is a lot of kids that are born with reflux have renal dysplasia and already have renal damage at birth. And when we look at those are the kids that end up usually in the transplant registries, and reflux nephropathy is still the 4th most common cause of end-stage renal disease in children. This is the RIVER study. As I said, there were strict definitions of urinary tract infection. The primary outcomes of febrile urinary tract infection, secondary outcomes was renal scarring. And if you look at the numbers, 98% of the kids that were enrolled were girls. A large percentage of them were low grade. So again, the study is questionable for high grade reflux, but for low grade reflux, 92%, 48% were bilateral. A large percentage did not have any scars, and a large percentage were diagnosed after the first febrile urinary tract infection. But what they found in the RIVER study is that there is a reduction in the rate of urinary tract infections with prophylactic antibiotics. And the individuals who actually benefited most with prophylaxis are girls and children that had bladder and bowel dysfunction. So bladder and bowel dysfunction, I'll go over that over and over again. I think it's really important to evaluate kids for bladder and bowel dysfunction, because that's one factor that you can actually work on that would help resolve or reduce the risk of urinary tract infection or even resolve reflux. So girls and kids with bladder and bowel dysfunction at high risk for urinary tract infection, that's where prophylaxis will work the best. When we look at UTI outcomes, again, there are lots of studies that have actually looked at urinary tract infections. This is divided into those that have low risk of bias. The RIVER study is one of them. And those are the ones that have high risk of bias, basically meaning that there's a lot of bias, so studies are not really well designed. But the ones that were well designed, there clearly is a decrease in the risk of urinary tract infection with prophylactic antibiotics. With the ones that were not designed, and those were the ones that the AAP looked at, and you see that the risk crosses 1 here. When you see those lines crossing 1, that means that it's not statistically significant. And those are the studies that have questioned the use of prophylactic antibiotics. But again, those studies were not really well designed. With the well-designed study, there clearly is a decrease. The risk of urinary tract infections decreased with antibiotic prophylaxis. But on the other hand, when you look at prophylaxis versus no prophylaxis in renal parenchymal abnormalities, there's really no difference. The only study that showed a reduced risk of scarring is the Swedish reflux scar study. But when prophylaxis short term does not seem to affect the risk of renal scarring. But even when you look at some of these studies, there's possibly some effect in total and new progressive renal scarring, and numbers are around 35% reduction in risk of scarring. I talked about the RIVER study. It did not show any difference between those that received placebo versus those that received treatment in developing renal scars. But again, those are studies that were short-term. They were only 2 years. So we don't know what the long-term effects of these are. On the other hand, the Swedish reflux studies, where they compared 3 arms, placebo, antibiotics, and deflux, with grades 3 to 4 reflux. If you look at prophylaxis, reduces the risk of scarring. Endoscopic treatment has a reduced risk of scarring, but again, girls are at higher risk of scarring than boys are. So should think about being a little bit more aggressive with girls that have vesico-ureteral reflux. This is a study that was retrospective, a lot of bias in that, showing that the higher grade refluxers are at highest risk of scarring. So the higher the grade, the higher the risk of scarring, to the point where grades 1 and 2 are the risk of scarring is extremely small, that you probably do not need to treat those kids with prophylaxis unless they have recurrent febrile urinary tract infection. The problem with antibiotic prophylaxis is resistance. With the RIVER studies, there's a 63% chance of resistance. There's not meta-analysis that looked at antibiotic resistance. So antibiotic resistance increases 8-fold with prophylaxis. So that's one of the negative things of prophylaxis, and you've got to consider that because a lot of these kids would get to resistance. So when you look at the risk of renal scarring, younger age, recurrent febrile urinary tract infection, high rate grade reflux at the highest risk for renal scarring. That's the reason why a lot of us would treat them with antibiotic prophylaxis in younger kids, kids with bladder bowel dysfunction, and kids with high grade reflux. So AUA guidelines basically recommend antibiotic prophylaxis in kids under the age of 1 that have a history of febrile urinary tract infection, kids that have high grade reflux regardless of UTI risk, and then any child that has bladder bowel dysfunction. So it's really important to figure out if these kids have bladder bowel dysfunction. They do have bladder bowel dysfunction. Antibiotic prophylaxis seems to have a protective effect. And then there are options as far as all the others in managing and treating with antibiotic prophylaxis. I talked about renal dysplasia. Those are congenital development, abnormal development, and you notice that with high-grade reflux, especially males, there's a higher risk of renal dysplasia, and those are prenatally diagnosed reflux. Voiding dysfunction, important. I think I consider every child with reflux that's diagnosed after febrile urinary tract infection, especially if they're around toilet training, to have bladder bowel dysfunction. So really treating the lower urinary tract infection because LUTD increases the risk of febrile UTI in children. We know that the resolution rate is lower if you don't treat the lower urinary tract infection, and also the post-operative UTI rate is much higher if they have LUTD. So really making sure that the lower urinary tract dysfunction is treated, you would reduce the risk of febrile urinary tract infection and also improve the resolution rate. This is again from a Swedish reflux study group that basically showed that the reflux resolution is higher in those without LUTDs and those with overactive bladder voiding dysfunction, and the risk of scarring is also higher in those children. When you look at resolution rate, again, bladder bowel dysfunction, low resolution rate, higher if they did not have bladder bowel dysfunction. When you look at operations, again, I would not use deflux in a kid with lower urinary tract dysfunction because the rate of success is very small. If they don't have lower urinary tract infection, deflux, for example, has an 89% success rate with bladder bowel dysfunction 50. Reimplants are successful in both conditions. You can predict the resolution rate. This is a study done by Boston Children's, and this is a website that you can go in there and plug in numbers of the child category, how they presented, the age of presentation, and then it will actually calculate the resolution rate for you. This is another calculator that is done by Dr. Curry at the University of California, Irvine. There's an app for that. You can actually, it's called the iReflux app. You can put it on your iPhone. And I use this quite a bit for counseling families and really counseling them on the rate of recurrent febrile urinary tract infections and managing in that way. So as far as guidelines are concerned, we can estimate the rate of resolution. We know that high-grade reflux are slower to resolve. And we can assess the risk of future urinary tract infections. So the AUA guidelines are in kids under the age of 1 that have no UTI, low-grade reflux, is really to observe those. We don't need to treat those. And those greater than 1 that have no bladder bowel dysfunction. What about surgery? We know that surgery can reduce the risk of urinary tract infections. And if you look at surgery versus prophylaxis during the first 5 years of life, there's really no difference between